CICU devices.
Intra-Aortic Balloon Pump, best responders. The intra-aortic balloon pump remains one of the most widely used forms of temporary mechanical circulatory support due to its simplicity, rapid bedside insertion, and broad clinical familiarity. For decades, it has been considered the first-line support strategy in cardiogenic shock across many centers. However, in recent years, several randomized clinical trials have failed to demonstrate a clear survival benefit, particularly in acute myocardial infarction-related shock. These findings have led to a re-evaluation of intra-aortic balloon pump role in modern shock management. Specifically, the device appears to play a clinically relevant role in selected patient subgroups where observational data suggest a potential benefit. In a previous video, we reviewed the current indications for IABP support, but now we will shift the focus toward identifying the patient profiles most likely to respond favorably to intra-aortic balloon pump therapy. Although randomized trials have failed to demonstrate a consistent mortality benefit in unselected patients, more recent observational and registry data suggest that certain subgroups of patients may derive clinical stabilization or survival benefit from IABP support. Understanding the characteristics of these responder patients could be essential to optimize patient selection. One of the turning points in this controversy was the publication of the IABP-SHOCK II trial in 2012. This trial enrolled patients with acute myocardial infarction complicated by cardiogenic shock and randomized them to intra-aortic balloon pump versus standard of care, all receiving early revascularization and optimal medical therapy. The study showed no significant difference in 30-day mortality. Moreover, mid- and long-term mortality did not differ significantly. These results dampened enthusiasm for routine intra-aortic balloon pump use in acute myocardial infarction-related cardiogenic shock. Indeed, systematic reviews and meta-analyses have concluded that routine intra-aortic balloon pump use does not confer a clear survival advantage in this population. From a pathophysiological standpoint, the success of intra-aortic balloon pump therapy hinges on several fundamental mechanisms. The device exerts its primary hemodynamic effects through diastolic augmentation, which increases aortic diastolic pressure and thereby enhances coronary perfusion, and through a modest but clinically relevant reduction in afterload produced by rapid balloon deflation at the onset of systole. Together, these actions aim to improve myocardial oxygen supply while simultaneously reducing oxygen demand. In addition, the counterpulsation mechanism is highly timing-dependent, precise synchronization of balloon inflation with diastole and deflation just before systole is essential for translating the device's mechanical action into effective pressure and flow changes. You can learn more about the intra-aortic balloon pump physiology in this video. The link can be found in the description. In addition, the definition of an intra-aortic balloon pump responder is not firmly established, but certain hemodynamic features can help characterize this favorable response. From a hemodynamic standpoint, responders typically demonstrate an immediate and measurable increase in cardiac output after IABP initiation, accompanied by a reduction in pulmonary capillary wedge pressure and mean pulmonary artery pressure, reflecting both improved forward stroke volume and relief of left-sided congestion. Some data suggest that intra-aortic balloon pump may still have a role in cardiogenic shock, especially in carefully selected patients. But which patients appear to respond better? In this sense, several factors emerge like etiology, right ventricle function, vascular properties, or mitral valve function. One of the main factors is the etiology. Following the negative findings of IABP-SHOCK II, increasing attention has shifted toward understanding which patient subgroups may still derive meaningful benefit. The underlying etiology and stage of shock significantly modulate the likelihood of response to intra-aortic balloon pump therapy. Comparative hemodynamic studies have demonstrated that patients with cardiogenic shock on the background of advanced decompensated chronic heart failure experience substantially greater augmentation of cardiac output with intra-aortic balloon pump support than those with acute myocardial infarction-related shock. In the latter group, the incremental hemodynamic benefit tends to be modest even under similar device settings. These differences underscore the importance of shock phenotype in guiding appropriate patient selection for intra-aortic balloon pump therapy. This way, one key group is patients with chronic systolic heart failure who decompensate and develop cardiogenic shock. This phenotype is often referred to as heart failure cardiogenic shock. The heart failure cardiogenic shock profile is characterized by a distinct constellation of hemodynamic and structural features, a markedly dilated and afterload-sensitive left ventricle, frequent presence of severe functional mitral regurgitation, chronic neurohormonal upregulation leading to systemic vasoconstriction, and a high-volume status with significantly elevated filling pressures. In this setting, the mechanical actions of the intra-aortic balloon pump align particularly well with the underlying pathophysiology, especially when some degree of contractile reserve is preserved. Whereas heart failure patients showed a moderate augmentation in cardiac output, acute myocardial infarction patients exhibited almost no improvement. Moreover, in heart failure patients, even relatively modest increases in cardiac output on the order of 0.5 liters per minute can be sufficient to achieve hemodynamic stabilization. In contrast, in the acute infarction phenotype, this level of augmentation, even when attained, is generally inadequate to stabilize the patient due to the abrupt and profound loss of left ventricular function. As noted, the expected improvement in cardiac output with IABP is typically modest and often insufficient to reverse the severe systemic hypoperfusion characteristic of acute myocardial injury. However, in patients with chronic heart failure who have adapted to persistently reduce cardiac output, even small increases in forward flow may restore hemodynamic balance. These patients often exhibit higher tissue oxygen extraction rates from circulating blood, allowing them to tolerate lower baseline cardiac output and derive meaningful benefit from the incremental support provided by the intra-aortic balloon pump. The optimal responder profile is also marked by preserved right ventricular function, a crucial determinant of successful intra-aortic balloon pump therapy. This preserved right ventricle function appears to prime patients for greater hemodynamic benefit because IABP does not provide direct mechanical support to the right ventricle. Instead, it relies on sufficient right-sided output to maintain adequate preload to the left ventricle, allowing the device's afterload reducing and diastolic augmenting effects to translate into improved forward flow. Consistent with this concept, patients who stabilize during intra-aortic balloon pump support typically demonstrate more favorable baseline right ventricle parameters. These include a pulmonary artery pulsatility index greater than 2.0, indicating preserved right ventricle pulsatility and the ability to generate effective pulmonary flow, as well as a lower central venous pressure, and a reduced central venous pressure to pulmonary capillary wedge pressure ratio. Vascular properties also appear to be important, as a vasoconstricted state allows intra-aortic balloon pump inflation-deflation to translate more effectively into pressure flow changes. Systemic vascular properties also influence the responder profile because the magnitude of pressure augmentation and afterload reduction generated by a given balloon volume depends on aortic compliance and systemic vascular resistance. Observational data indicate that higher baseline systemic vascular resistance is associated with better early hemodynamic response in chronic systolic heart failure patients, plausibly because these patients experience a greater drop in effective afterload when the balloon deflates in early systole, thereby unmasking latent contractile reserve. For example, in a retrospective study of 218 patients, systemic vascular resistance above 1,300 dynes per second per centimeter to the -5 emerged as a significant predictor of intra-aortic balloon pump responsiveness. Patients above this threshold were more likely to demonstrate meaningful improvements in cardiac output and pressure-based indices soon after counterpulsation was initiated. This reinforces the concept that vascular tone is not merely a background variable, but a key determinant of the mechanical benefit achieved with intra-aortic balloon pump therapy. In parallel, case-based physiologic analyses suggest that lower aortic compliance, although usually viewed as detrimental in cardiovascular disease, may paradoxically enhance intra-aortic balloon pump effectiveness by amplifying both diastolic pressure augmentation and the fall in end-systolic pressure, particularly in patients with reduced ejection fraction and severe congestion. On the other hand, patients with an associated inflammatory state tend to exhibit a reduced hemodynamic response to the IABP therapy. Mitral valve function further helps delineate the responder phenotype in cardiogenic shock supported with intra-aortic balloon pump. Moderate to severe functional mitral regurgitation has been identified as a predictor of early hemodynamic response, likely because afterload reduction decreases the regurgitant fraction and left atrial pressure while more prominently augmenting stroke volume. Intra-aortic balloon pump performance also depends on sufficient myocardial reserve, since the efficacy of the device relies on effective displacement of blood within the aorta. The heart must generate sufficient hydraulic power to produce an adequate ejection with each beat. Particularly in patients with chronic heart failure, a left ventricular cardiac power output index of more than 0.33 watts per meter squared has been shown to identify those who are likely to achieve hemodynamic stabilization during intra-aortic balloon pump support. For the average adult, this threshold roughly corresponds to an absolute cardiac power output of 0.6 watts, assuming a typical body surface area. This relationship underscores the concept that a minimum level of intrinsic ventricular performance is necessary for the mechanical assistance provided by the device to translate into meaningful improvements in forward flow and systemic perfusion. The response to intra-aortic balloon pump may also depend on the severity of cardiogenic shock, which is now commonly graded using the SCAI classification. In a recent meta-analysis evaluating outcomes across SCAI stages, subgroup analysis demonstrated significantly higher 60-day survival or successful bridge to heart replacement therapy in patients classified within the SCAI C or D cohort. These findings suggest that patients in intermediate stages of shock who are neither too early nor too advanced in the shock trajectory may derive the greatest benefit from intra-aortic balloon pump support. Consequently, the prototypical responder to intra-aortic balloon pump therapy in cardiogenic shock can be characterized by a constellation of clinical and hemodynamic features rather than a single defining criterion. These patients are typically those with decompensated chronic systolic heart failure or other forms of cardiogenic shock in which myocardial injury is less abrupt and extensive than in acute myocardial infarction. They most often fall within SCAI stages C or D, where shock is significant but still potentially amenable to stabilization with moderate hemodynamic augmentation. Because the intra-aortic balloon pump exerts its primary effects on the left ventricle, responders tend to have preserved right ventricular function, ensuring adequate preload delivery to support forward flow after afterload reduction. Favorable right-sided parameters include a pulmonary artery pulsatility index greater than 2.0. Systemic vascular tone is another key determinant. Patients demonstrating high systemic vascular resistance, typically above 1,300 dynes per second per centimeter to the -5, have shown better early hemodynamic response to intra-aortic balloon pump. This may reflect a more afterload-sensitive physiology in which balloon deflation in early systole produces a more pronounced drop in effective afterload, thereby revealing residual contractile reserve. A preserved, though impaired, level of left ventricular hydraulic power is also required for balloon counterpulsation to translate into meaningful circulatory benefit. Thus, responders often have low cardiac power output, consistent with shock, but still more than 0.6 watts, indicating some remaining contractile reserve. Pulmonary congestion also contributes to the responder profile. Based on the principle of volume displacement, higher degrees of pulmonary congestion reflected in elevated mean pulmonary artery pressure and capillary wedge pressure may ensure adequate left ventricle preload, enabling the device to generate more effective diastolic augmentation and systolic unloading. Similarly, significant functional mitral regurgitation may predict benefit, as afterload reduction can decrease regurgitant volume and improve forward stroke output. Heart rate also plays an important role. Because counterpulsation requires precise timing of balloon inflation and deflation, tachycardia markedly reduces device effectiveness. A baseline heart rate less than 92 beats per minute has been identified as a predictor of successful stabilization following insertion. And finally, though no less important, responders must have no major contraindications, such as severe peripheral vascular disease, severe aortic regurgitation, or irreversible multi-organ failure, because these conditions limit both the applicability and the potential benefit of intra-aortic balloon pump therapy.
If you've enjoyed our video, please press the like button and subscribe to support us so we can continue creating quality content like this.